The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell from Leading Age Michigan, and I'd like to welcome you all again to our Wednesday Safe and Calm webinar for August 12th. Before we get started this morning, I would like to let everyone know that we will not be holding our Friday webinar this week, but we will convene next week on Wednesday, August 19th. As usual, our presentation this morning will start with an advocacy update from Dalton Herbal, followed by our situation update, and we will end with resources and guidance. We have moved nursing home only topics to the very end, and our guidance review is going to focus this morning on transmission-based precautions. So at this point, we will turn the presentation over to Dalton, our Director for Advocacy.
Good morning, everyone, and welcome to today's call. Our advocacy agenda for today will be discussing the fact that the governor vetoed Senate Bill 899, some CON commission appointments that were made, Michigan updates a possible strike in Metro Detroit, and some updates to the federal stimulus package. Before we begin that, though, I would like to make a plug, like I did last week, for our fully virtual Leadership Institute that will take place September 9th and 10th. It will feature state and legislative updates, finance and reimbursement trends, regulation and guidance discussions, strategic planning, innovative programming, and networking opportunities. We have a pretty good lineup of speakers, as you can tell on the next slide. As the thumbs up would say, I'm very positive about these speakers. We have invited Dr. Robert Gordon, the Director of Laura, Larry Horvath, Senior Deputy Director of AASA, Dr. Alexis Travis, and the Director of the House Fiscal Agency, Mary Ann Cleary. And you can go to leadingagemi.org to register. I believe registration is now open, so please feel free to go over there and register yourself. Into some Michigan updates. I apologize for the massive amount of text on this slide. I won't be addressing it all, but I just want to provide background for those who like to take a deeper dive into the slides. First off, the governor vetoed SB Senate Bill 899 as we thought. This is the legal liability protections bill. It would have provided legal liability from civil, or would have provided civil liability protections for a variety of healthcare facilities. We heard the governor was going to veto it. Throughout the process, Democrats were largely opposed to the legislation without making a couple of changes, and their amendments were largely not taken into account. So it was not really a surprise that she vetoed this, but it was something that we were pushing for pretty hard. Also, the governor also appointed new CON commissioners. Those are Justin Dimmick, Amy Engelhart Kabelfleisch, I'm guessing that's how you pronounce that, James Falhey, who's being reappointed, Asha Condor, and Larissa McAllister. None of them are being appointed to represent long-term care facilities, but we have two of them are being appointed to represent physicians. One is being appointed to represent hospitals, and another is being appointed to represent kind of the general public. The CON commission, the number of commissioners was actually expanded this year under a couple of CON bills, and so you're seeing some new faces added and then some people being reappointed or taking over for those whose terms expired. As for updates in the legislature, this week the legislature is primarily focused on education and back to school issues. But on Thursday, there'll be a joint panel between the House and the Senate to question Dr. Robert Gordon about contact tracing. And then the final legislative day for this month, or legislative session day for this month, is going to be on Saturday, which is you don't usually see a Saturday in there. on the calendar, but they added it because they want to make sure they get all the back to school stuff done before the start of September, when schools are actually supposed to go back. The House has kind of made public what their plan is a little bit. Some highlights of the package. It's still very rough, but some highlights include allowing schools to conduct e-learning days instead of in-person days. These in-learning days would still count towards the attendance figures for the schools, because as you know, schools in Michigan are funded by attendance counts. And so this would allow schools to still receive funding while educating students from home. At one point, there were requirements for in-person learning for K through 5 students. They're not in the package right now, but they were considered earlier on. So that's something to keep an eye out for. It would also require schools to get parental consent for e-learning. It would, as I said, waive the required minimum amount of days and hours of education a student needs in a year to be considered as having fulfilled that year of education. Schools would have to submit plans to the state, and schools would actually have to have tests to receive funding. So they'd have to actually have benchmarking exams. I believe it's 30 days after the end of every quarter for them to receive funds. There are other options being considered, and negotiations are still ongoing between the Senate and Governor and House. I thought an interesting kind of solution to this is that they were talking about at one point was education pods. This would be putting students in small teams and having them work together in person in any public setting they so choose, but the teacher would then either go in person or Skype or Zoom or video chat into these pods and help them with their instruction. Moving on to the possible strike in Metro Detroit. On August 17th, 1,600 Detroit nursing home workers plan to go on strike. They're citing unfair labor practices that illustrate the industry's failure to keep workers and residents safe. Interestingly enough, these workers represent 18 nursing facilities across Metro Detroit, all but 2 of which are represented by for-profit nursing home chains, Villa, Sienna, Charles, and Dunn. I believe it's Charles Dunn, though. And then a quote that was taken from the rally that I thought stood out to me, at least, is, "We're called essential, but we're treated like we're expendable. We're calling on nursing home owners to pay us a living wage so we can afford to get health care, just like we provide it, and put in place proper safety protocols and guaranteed PPE throughout the pandemic." I attached a link to an MLive article that discusses the strike if you're interested. Let me get a sip of water here. My voice is going. I apologize. A brief update on the stimulus package at the federal level. Negotiations are still ongoing, and you may have heard of President Trump signing some executive orders to extend some programs. The final details about these programs aren't released, and they may face some legal challenges based upon what he's trying to do. What we know right now, though, kind of the big highlights are that he extended the $400 a week unemployment benefit and made it so that states would have to cover 25% of the cost of that benefit. So they'd essentially have to cover $100 of the $400 a week employment benefit. This is down from $600. This puts a lot of pressures on states whose budgets are already kind of tight, or those who have spent all their COVID dollars, like us in Michigan. And so we'll stay tuned to see what this does and what impact this would have on Michigan going forward. He opted to defer student loan payments, and he had wanted to defer the employee portion of the federal payroll tax from April 1st to the end of the year. Right now, those taxes would have to be paid back at the end of the year, but we'll see what happens. He plans to have Congress take some kind of action on that, I believe, but we'll see. He also wanted to have efforts to halt evictions through his orders. How it would actually work is kind of up in the air. He asked the Department of Treasury to look at covering the cost of paying rent for those who can't afford it and how much that would cost. So I think he's looking at more of a solution around that rather than just deferring evictions in full. And then just a brief review of the topics that are being discussed at the national level in terms of stimulus package. There's $175 billion in healthcare provider relief funds that haven't been distributed, and then $100 billion more requested for physicians and hospitals. There's Medicare loans, liability protections, telehealth policy extensions, COVID testing funds by commercial insurers, state and local funding to insulate budgets. We're watching this because this will have an impact on our Medicaid rate and the state going forward. Hazard pay and child care subsidies requested by hospitals and healthcare providers is a new thing that's entered discussion. COBRA subsidies have also entered the discussion, and funding for FQHCs has also been included.
All right, thank you very much for that, Dalton. Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the names up on the screen right now. These are some of the organizations that continue to support the association and your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. Just to touch off of Dalton's plug earlier, as far as the Leadership Institute goes, we also have sponsor availability for that, sponsorship opportunities. So you can go ahead and check those out. If you go to leadingagemi.org, if you hover over the little events tab, you'll see something that says conferences. And then that will be a little sidebar, I guess I would say, that pops out. And you can go ahead and click on the 2020 Leadership Institute, and that will have links to both the registration page and the sponsor page, and you can get a little bit more information on that. As of right now, it doesn't look like I have any questions, so we can keep on moving forward. Thank you.
Thank you, everyone.
Well, thanks, Blake and Dalton. So next, we're going to look at the updated COVID data. And this morning, we're going to take a quick look at some of the data from our surrounding states and see how we compare. This is the global picture based on data from the WHO through August 10. This represents daily new cases, and it does finally seem to be, at least globally, leveling off again. So that's good news. This next slide, these are daily caseload graphs for the U.S. And comparison graphs for several states surrounding Michigan, including Illinois, Wisconsin, Indiana, and Ohio. And I know that these graphs are small, but it's really the trends that we were really trying to look at here. In other words, that's the shape of the graphs. These slides were developed by the Kaiser Family Foundation. And one of the issues is that with the graphs is that the range on the far left for each graph is different. So although we're looking at the trends or the shape, you have to note that the red bar in each of the state graphs represents 1,000 cases per day. So you can see how that bar moves up and down with each state. The U.S. graph represents 50,000 cases per day. And this week, nationally, we did finally get under 50,000 per day for at least 2 days. So hopefully that's finally leveling off as well on average. If you look at the recent daily caseload in Michigan, compared to the other states, you'll see that the actual number of daily cases is far less in Michigan over the past several weeks. All the states show an initial peak and then a rebound. You'll note that Michigan's peak came earliest, but diminished quickly. And now, like other states, is rebounding a bit in similar ways to Indiana and Wisconsin. But Illinois and Ohio are experiencing very, very high daily case numbers. This graphic shows the cumulative trends in caseload over time as of August 11. And again, this is a Kaiser Family Foundation product. Michigan is the very light blue line that you can see. It falls in the middle, kind of following Illinois and Ohio. But you'll see that over time, Ohio's cumulative cases are very near Michigan's. In terms of cumulative deaths, Michigan's numbers compared to other states are a bit higher, and only follows Illinois in the number of overall deaths. So we do a lot better in terms of caseload, but we're still, in terms of cumulative deaths, pretty high. It's the number of cases per million population, however, that we think is the most telling data. You'll note that Illinois has higher cases than the national average per population, and that Michigan fares better off than all nearby states except for Ohio, oddly enough. But Ohio's numbers are likely to change because their transmission rates right now are very, very high. When looking at the 7-day rolling average of new cases, you can see Michigan is experiencing fewer actually than all the others. And again, you can begin to see how Ohio is spiking. As part of its review, the Kaiser Family Foundation has also done a review of state-to-state comparisons for adults at risk. So across the U.S., 21% of all adults under 65 have significant risk factors for COVID. And it's a bit higher, 25% in Michigan. Only 7 states have a higher percentage of working age adults with higher percentages of risk. And all of them are in the Southeast. Oklahoma matches our average of 25%. So we have a lot of persons who are working age, who have a lot of comorbidities that puts them a little bit more at risk than in other states. In looking at all adults at risk, based on age or on comorbidities, 55% across the U.S. are seniors. And 53% of Michigan at-risk adults are seniors. And in Michigan overall, if you're going to measure all of the adults working age over 18, 41% of adults in Michigan are at risk, either based on comorbidities or age. So this slide just demonstrates the number of senior adults who have died from COVID and how it varies from state to state. And 61% of all senior deaths were persons from 7 states. So those first 7 states on the slide account for 61% of all senior deaths, and Michigan is included as the 7th state in that listing. Here's our routine daily case trend graph using, again, a 7-day rolling average. There was a slight uptick yesterday, but it does appear, thankfully, that Michigan numbers have at least leveled off. They're not declining, but they have leveled off. And in terms of deaths, we had a little bit of a peak a few weeks ago. They appear to be leveling off and stabilized as well. And last, but perhaps more directly impacting members, is the fact that the My Safe Start map, as of yesterday, continues to show moderate to high risk across most of the state, which means that nursing homes will be doing weekly staff testing for a while yet. We're now going to move on to a review of resources and guidance, and we will be reviewing the CDC guidance on transmission-based precautions this morning. I apologize a bit in advance that we keep talking about the same content over and over again, but it feels important because there's so much confusion and detail to deal with. In some of the upcoming slides, you'll see some repeated content as well, but that's because we are reviewing and comparing different parts of the CDC guidance. So this morning we're going to start with the executive orders issued since last we talked about them, and there are two that have been issued that impact members. Executive Order 166 provides the requirements regarding how employers must handle employees with suspected or confirmed COVID. It's an extension of a previous order that's been in place throughout pretty much throughout the pandemic, and it has a few updates. And of course, on Monday, the governor issued Executive Order 169, which is an extension of 148. And we talked about 148 last week. We'll review it really briefly again today. And that extension goes till September 7th. So basically, Executive Order 166 is the repeat of an earlier order about employees with suspected or confirmed COVID and pretty much what their rights are. Basically, employers cannot discipline anyone who stays at home because they are at risk of infecting others. The highlighted text includes updated language, and that language now aligns with the recent CDC guidance for return to work criteria. So since the period of transmission-based precautions. Can you all hear me?
Yeah, we can. You cut out for a second, but we can hear you.
Oh, I don't know what happened there, but I got a strange message. Anyway, I'm sorry. So the highlighted text includes updated language from the CDC for return to work criteria. And positive or suspected persons must stay at home until 24 hours. They're fever-free without meds, and 10 days after symptom onset. And those requirements are a little bit shorter than they were originally. So this guidance has been updated in particular to address that piece. So the other thing it does, it also mandates that persons who have close contacts, and they identify close contact as 6 feet within someone who is thought to be COVID positive for at least 15 minutes. Persons who have those contacts must stay home for 14 days, but there are exceptions for healthcare workers and other healthcare responders. So obviously, if you're working with people who have COVID in a facility, you are expected to continue to go to work because there are protections for you. The other area updated in this guidance is the symptoms that we should be alert for. And this has also changed since the updates from the CDC. So instead of the 4 or 5 respiratory related symptoms, they include now all of the symptoms that we should be concerned about based on what the CDC is saying. On Monday, the governor extended what was Executive Order 148, protections for healthcare workers and residents. This is what I at least call the regional hub order, since it started with an introduction to the regional hubs, but it has been refined over time. We did review this order last week because it was the focus for the Attorney General review. Nothing in the wording has changed. It has simply extended those requirements to September 7. But I always want to point out that this order has evolved along the way, and it's a bit more flexible in the language than originally. They mandated certain uses of dedicated units, etc. in the beginning. So now it's only nursing homes who have to make a reasonable attempt at creating a dedicated unit. And while it's not stated here, there is MDHHS guidance that reserves the use of these regional hubs to persons coming out of nursing homes or hospitals. So even though it doesn't say that other facility types can't use a regional hub, the reality is that they cannot. Alternate care facilities are also stated as an option, but in reality, they have never really been in existence to any major degree at all. And there's language here that says that COVID positive hospital discharges can go back to the originating facility. Doesn't talk about dedicated units. It says that they can go back to the originating facility, but only if that facility is capable of isolating the person, consistent with CDC and MDHHS guidelines. So in a call with the department earlier this week, the department said that they had decertified a few of the regional hubs, and the rest of them are really only at 50% of their capacity at this point. So a lot of those regional hub beds are empty. This is also the guidance that covers 4 entities. It does not cover independent living. That's one point of confusion that keeps happening throughout many of the members, is that this is not covering independent living at all, but it does cancel all communal dining, and we talked a little bit about that last week. The CDC has updated its toolkit that they put out. I'm sorry, I said CDC, but I meant CMS. This is a CMS guidance that lists the best practices across states. And they updated it this week. This guidance covers all actions that the states have taken to address all the topics listed on the slide. You might want to take a moment and review what it says about Michigan regional hubs. It's kind of interesting. And I'm not sure that when we've looked at this, there's not a whole lot that is exciting or different here. But it is a good review of what's going on in other states. Additionally, CMS has developed a counseling checklist for use when a person is being tested either routinely for COVID or in response to symptoms. This checklist is meant to kind of help and push the discussion about what will happen if findings are positive, and it's meant to prepare persons in advance. There are also tools and resources for consumer education that are linked from this guidance. So next we're going to talk about provider relief grants. We're right in the middle of some upcoming due dates about those. And as we were looking at the information available, we noticed that there's a little bit of different website information as opposed to what's come out in recent press releases. And I at least found it somewhat confusing. I do think that perhaps they're not updating all the language and links on the website as fast as the press releases are coming out. So some of that information on the website might be old. So phase 1 started with a distribution of $30 million based on the amount of Medicare revenue provided in 2019 or 2018 as needed. And then they adjusted this formula and decided that providers instead should get 2% of all patient care revenue, not just Medicare revenue. And so they gave providers an opportunity to submit updated information if they hadn't gotten at least 2% of all patient care revenues in the first distribution. And the deadline for that was June 3rd. But HHS has now extended that, and providers who are still under that 2% threshold can submit information via the portal from August 10 to August 28. So the press release said that this would also include providers who are primarily funded through Medicaid, but in the initial payment only got a small amount of money because they have low Medicare usage. So they also now can get up to 2% of their total patient revenues by sending financial information through the portal during the same time frame. So this is what the website says about phase 2 eligibility. and that's on the right. It seems there's some confusion about where phase 1 ends and where phase 2 starts, but I don't think it really matters in terms of making sure that you just submit information if you want to take the grant on a timely basis. The phase 2 press release states that new owners in 2020 who did not get any funding because they had no income in 2019 can also apply. So that's a new category of person. And any providers who had no Medicare incomes in 2019 can also apply, and those might be Medicaid-only providers. And anyone who missed the June 3rd deadline to update their financial information if they're still under the 2% cap can also apply. But it's important to know that providers will only get a total of 2% of their patient care revenue, regardless of what phase they're in. And of course, they all must accept HHS terms. The website simply says that phase 2 is for those who received no money in phase 1, but all of those scenarios that we just talked about do also apply. It's just not clear on the website. Providers have to have provided some care sometime after January 1 this year, but could not have permanently ceased operations. And the link to the website in the portal is on the screen. And if you haven't done all your submissions, I suggest you look there. In terms of those HHS terms and conditions, there is an attestation and reporting requirement. Funds must be used to cover lost revenue due to COVID and any additional expenses for things like supplies, testing, training, any COVID-related construction that you may have had to do. The reporting system will be available starting October 1, and all must report any of their 2020 expenses by February 15th. For providers whose expenses may continue into 2021, providers will have until July 31st to report. Detailed reporting requirements will be available starting around next week, according to HHS and CMS, but you never really know when they're going to come out, along with a template for submission. For nursing homes, there's an additional payment coming from that totals $5 million more from the CARE Act funds, and it's allocated specifically to nursing homes. For these funds, though, CMS is expecting to link some of the funds to performance and some training requirements. $2.5 billion are to be distributed in August, so members should be getting checks shortly to support testing, staffing, and PPE. The rest of the money is going to be linked to nursing home performance and perhaps some training requirements, with the focus on nursing homes who, moving forward, perform average or better than average when looking at transmission rates in the community compared to the facility. But the formula for this has not yet been developed. The press release noted that 40% of all COVID deaths to date have occurred in nursing homes, and there is some planning. There's some planning. I'm not sure if I'm on this slide or the next slide. Can you move it forward? Yeah, here we go. And there's some planning that there will be work using the 2019 quality roadmap that CMS put out, and that was designed by Dr. Pronovost from Cleveland Clinic. And CMS will also be working with Project ECHO to pilot a nursing home learning network specifically for infection control. The process for provider relief grants has been so messy that we strongly encourage members to participate in the HHS webinar tomorrow that explains all this in more detail. The registration link is here. I don't know if there's any limitations to how many people can attend, but we strongly suggest that if you haven't gotten all of your grant money yet, that you might want to participate. At this point, we want to take a brief moment to acknowledge the healthcare workers that are lost to COVID. Michigan has lost 22 health workers to COVID, and we think it's important to acknowledge and recognize them for their service to patients and residents and seniors. The Kaiser Family Foundation has a program specifically designed to honor them, and they are trying to collect information on each person. At this point, they've reviewed cases of 167 of the 922 workers who have died across the nation. And their goal is to highlight some of the issues that they're facing and some of the difficulties. So they identified that many worked in facilities that had shortages of PPE, and that persons of color were again disproportionately included in that group. 31% of the 167 that they looked at had inadequate PPE, and 46% were over age 60. And many of these persons were immigrants. The foundation continues to gather information about healthcare workers and why so many have fallen ill. And members can help recognize these workers by visiting the website, and that is listed on the screen. HUD inspections are returning as announced on, the HUD announced it on August 7th. Standard 14-day inspections will resume after 9/21, and they're expected to start in the first week of October. These inspections are going to focus on buildings in low transmission areas and for those who have had low scores previously. Leading Age specifically asked HUD to avoid senior housing because of the COVID risk, but that doesn't seem to have changed their plans to date. So HUD has developed a heat map to identify states with lower transmission, which is their focus for inspections. You can see that Michigan is in the moderately low category, and only Vermont is in the low category. So we think we can expect inspections in the state here soon. Here are some of the additional learning opportunities coming up. The CMS nursing home call is scheduled for later today. The joint provider training is also going to be virtual program this time around with a focus on COVID-related issues. And Leading Age is holding its weekly conference call on the next two following Mondays, and those will include HUD engaged staff. So the first one is on Inspire, and the second one will be on fair housing. There's also a CMS webinar on transparency and notifications. It is scheduled for tomorrow in the late afternoon, if anyone's interested in that educational opportunity as well. So before we move on to transmission-based guidelines, let's take a moment and pause for questions or comments.
All right. Thank you for that, Deanna. Again, Leading Age Michigan would just like to thank our business partners. Please take a glance up at the screen right now and see all the logos. These are everyone who has stuck with us for our annual conference and are sticking with us until we get a new date set for that. So if you are looking for any type, if you are considering a purchase of goods or services, please remember this page of logos, the names of the organizations before and the organizations coming up near the end of this webinar. All right, now I do have a few questions, so let me pull those up really quick. All right. Was there any movement this week with MDHHS updating their June 4 guidance to protect Residents of long-term care facilities, upon readmission or current stay, last week it was mentioned that we may contact them for an update.
No, there has been no update to date.
Okay. Regarding our staff and visitor screening, which symptoms should we be using as we use the same form for staff and visitors, the CDC symptoms or EO 2020-166 symptoms?
Well, I would use both if I could. I guess I think that they're very, very close. I think that if you can't determine an alternative cause for certain symptoms, for me, my asthma is a little bit out of control right now, so we know why I'm a little hoarse and I have a cough. But if you can't determine a cause for some of those symptoms, you have to presume that that person could be COVID positive and act on that. I actually did not compare the CDC to the EO guidance specifically, but I think they're pretty close.
Okay. There is a statement on the CDC website which states that employers should not require a negative test or doctor's note before having a previously positive employee return to work. I have seen other statements which show it is okay to have these requirements. Can you provide any clarification?
Can you repeat that, please?
Yep, no problem. There is a statement on the CDC website which states that employers should not require a negative test or doctor's note before having a previously positive employee return to work. I have seen other statements which show it is okay to have these requirements. Can you provide any clarification?
So in the last month or so, the CDC has moved away from its test-based strategy in order to determine when it's okay to return to work or to discontinue transmission-based precautions. They prefer a symptom-based strategy, which is that 24-hour and 10-day piece, 24 hours since the last fever without meds and 10 days since the onset of symptoms, or a positive test if there were no symptoms. So those are the current guidance. Testing alone without the symptom updates is not considered a safe thing to do. And in fact, once you're positive, they suggest you don't test at all for 6 to 8 weeks. So my understanding of the guidance is that the preferred route is symptom-based, and that testing really doesn't get you anywhere once somebody's positive.
It would be helpful if you also showed the recovered in the state. The state website shows that 63,636 people have recovered, so that means about 30,000 is currently active.
Right, I can do that if members find that helpful, certainly.
All right. Can you please speak to the upcoming deadline for the submission of the MDHHS form for the additional $2 per hour COVID add-on for direct care workers?
I do know that there's a reimbursement form for submission. I've not reviewed those requirements recently. I would have to do a little bit of investigation. If there's a specific question about it, I can research that, but right now off the top of my head, I'm not prepared to do that.
Okay. Can you please clarify EO 169 as it relates to IL, communal dining and activities? Can IL resume either of these now under this order?
So this is one of those gray areas that's very confusing. There's nothing in state guidance that says that independent living level facilities have to stop communal dining. The only requirements for independent living facilities in the executive orders in terms of COVID care is that you must restrict visitation and you must screen everyone coming in and out of the building. Those are the only two requirements for independent living. However, the CDC guidance strongly recommends, especially if you're in an area of a significant transmission, that you do limit and restrict and avoid communal activities and communal dining. So there's no hard and fast rule in Michigan that stops you from doing it. You do have to be aware, however, of the risks that you might be taking if you do that. Social distancing is required, of course, in any kind of venue like that. But pretty much, again, it's a gray area, and each facility will have to determine, its own risks and how it wants to move forward. There's no hard and fast guidance that says independent living had to close their communal dining. Only nursing homes, AFCs, HFAs, and assisted living.
Has there been any discussion on compensating staff who come in when they are not working for weekly COVID testing?
No, not that I'm aware of. We haven't been doing much discussing lately with the state about testing. I think they figured pretty much their protocols out. That is something that we could forward to them, but as far as I know, there's no discussion at this time.
All right. There is research data that demonstrates that the cloth mask can be as effective or better than disposable ear loop masks. Recently, a surveyor is saying you must use up all PPE before using cloth, which is not rational since we may need disposable with an outbreak. Is there any unity on mask use recommendations?
CDC clearly says that cloth masks are not PPE and that they should not be used for any kind of movement, worker movement in a direct care area. You're required to use a surgical level mask at a minimum. Cloth masks are only okay for visitors, for residents, and for staff who are not working in direct patient care areas. So the CDC is pretty clear about that.
All right, thank you, Deanna. That was the last question for now, so we can keep moving forward.
Okay, so last week we did talk about the MDHHS guidance and on which PPE to wear for which level setting, and I at least found it somewhat confusing and not updated. And we have kind of sent that message to the state. We've not heard back from them. But today, what I wanted to do is go through the CDC guidance for the same kinds of things. And I think that you'll find that even though the CDC website is a little difficult to negotiate and it's repetitive in some ways, that I think that there's a clearer picture about what you're supposed to do from the CDC. So we're going to look at the infection control requirements for COVID as identified by the CDC, and obviously this comes from their website, and the link is at the top of the page. And note that the first part of this discussion is about guidance that are for all healthcare facilities. It's not limited to nursing homes. So in that guidance, staff must use standard precautions, obviously, and transmission-based precautions for COVID suspected or positive residents. Universal source control measures have to be in place. And that's based on the concept that anyone can be infected at this point. At a minimum, all staff must wear some sort of face covering. It can be cloth if you're not working in a direct resident area. Absolutely everyone in a facility, and note again that this is not specific to nursing homes, should be wearing a face covering, including residents when they're outside their rooms and visitors, if there are any. Residents also have to cover their faces when staff are in their rooms, if it's possible, or use a tissue or something if needed. Care staff must wear a face mask, not a cloth mask, at all times when in the facility, including in their break rooms and when they're not in a specific patient care room. Additionally, the CDC suggests that workers should consider wearing the same face mask throughout the shift. They feel that this will reduce the number of times staff must touch the mask and risk contamination to themselves as they change the mask. So staff should not be switching back and forth from face mask to cloth mask during the day based on what they're doing. Additionally, healthcare staff, and again, this is not specific to just nursing homes, need to use personal protective equipment in addition if they are in areas of moderate to substantial transmission. And that includes the entire state of Michigan right now. Standard precautions, of course, must be followed, and transmission-based precautions must be used for any COVID-related care, either for individuals or within areas of the facility where there's been some transmission. So staff in all Michigan healthcare facilities are now required to wear eye protection if they are in a direct care area, according to the CDC. This can be a shield or goggles, but it must cover the entire area around the eyes. Simple eyeglasses are not okay for that use. N95 respirators, while technically recommended for COVID care, are meant to be used only when there is a respiratory care program in place, and they can be appropriately fitted. The CDC actually recommends that these be reserved for aerosol generating procedures, and that surgical grade face masks should suffice for long-term care facilities. So, and then there's a paragraph on the website about looking for the requirements for low transmission areas, since the eye gear is required for medium to high. But oddly, there was not much difference in what the requirements were. So pretty much everyone needs to be wearing face shields or goggles. So the CDC identifies a list of aerosol generating procedures. Basically, I only included those that are appropriate for long-term care facilities. Obviously, some very invasive procedures in hospitals are going to be aerosol generating. But these include things like suctioning, sputum induction. They technically include specimen gathering for COVID. But then again, the CDC suggests that face masks should be used for that, since N95s are in short supply. Obviously for CPR. The CDC also states that it's unclear about the level of possible transmission during nebulizer treatments, as well as high O2 delivery processes. They suggest nebulizer treatments be changed to inhalers if possible, and that staff should be careful, but they're not recommending N95 masks yet for these procedures. So again, these are all requirements for general nursing care in all healthcare facilities. For residents who are suspected to have or have tested positive, they of course must be isolated, but airborne infection isolation rooms are not required. Only residents with the same pathogen should be in the same room, or they can be in a dedicated unit. Don't include suspected COVID residents or residents under observation within any dedicated COVID units. If they don't have COVID, you will just end up infecting them. Limit the number of transfers from room to room while persons are infectious, and limit transport out of the resident room by the resident to only absolutely essential activities. And of course, after vacating, you're supposed to allow sufficient time for air exchanges before terminal cleaning, and I think that there's guidance about what that looks like on another part of the website. So when there is suspected or confirmed COVID, and it's important to remember that persons admitted from a hospital must be in observation for 14 days and must be treated as if they have COVID, which means that staff should adhere to full PPE and transmission-based precautions. And that means standard precautions, contact, and droplet. We have seen some guidance that includes airborne, but the CDC does not. and that's not their recommendation that airborne precautions are necessary. Hand hygiene, of course, before and after all resident contact, any contact with infectious material before donning and doffing PPE, and between any glove changes. This is all standard procedures anyway. Facilities should also review the OSHA guidelines, and I think there's a link here to ensure that they are using the right PPE products. And of course, ongoing training on when and what PPE to use, how to don and doff, how to dispose and disinfect, as well as the limitations of what PPE can actually do for in terms of safety and precautions. That's an ongoing thing that facilities should consider, especially considering that's an area of frequent citation from the surveyors, at least for nursing homes. Again, remember that cloth face coverings are not PPE and should not be worn for resident care. If using N95 masks, they should always be applied before entering a COVID positive unit. Disposable equipment should be removed and discarded after exiting unless you are extending use. It is important to remember that if you have COVID positive persons, but you have to ensure that you're not moving persons and staff in and out of a dedicated unit. And if you're extending PPE, you specifically have to make sure that you're removing and changing PPE before dealing with non-COVID related residents. Also, guidance states that staff should ensure that eyewear doesn't interfere with the positioning of the face mask. Gloves, of course, should be changed and discarded after each use. And the CDC recommends changing gowns as well after use, but there are extended uses for that if you're working in a dedicated area. So when using transmission-based precautions, remember that for COVID, you must include standard contact and droplet precautions. If you're unsure of a person's diagnosis, the general rule is to use the highest level of necessary precautions based on the resident's symptoms until confirmed. So those are all the general guidelines for healthcare facilities. We're briefly going to now review those that are specific to long-term care facilities. And some of this will overlap, but each piece kind of includes some additional considerations and information as well. So the CDC link is at the top of the screen, and facilities are encouraged to use the ICAR tool, which is the Infection Prevention and Control Assessment tool, specific to nursing homes, but it really is all about COVID. And it really is kind of designed for an external review by an external party of practices. It focuses on an interview with what the state of transmission is in your local area, in your facility, and what your current practice is and how you're addressing all of that. And it pretty much embodies the entire list in general. It's very general of those things that you need to do based on CDC guidance. The same PPE requirements exist for long-term care providers, and new admissions, again, must be placed in a separate room or observation for 14 days if you're in an area of substantial transmission, and that is required in Michigan. It doesn't matter if the person is tested negative or not. Testing after observation can be used to increase certainty, but it doesn't replace that 14-day quarantine. So here is the updated list of symptoms to consider, and again, I would, if there are symptoms that differ between this and the executive order, I would combine them and make sure that they were all included. Any of these symptoms need to be investigated, and if there's no cause obvious for these symptoms, you must consider that person is potentially infected, whether it's a resident or staff. That's what you need to do. In the CDC guidance, dedicated units are considered best, but a private room is allowed. In the executive order, it speaks to attempting to move persons to a dedicated unit or to a regional hub. The language actually doesn't mandate it anymore. It also says that the consumer can be moved back to the originating facility as long as they can maintain the infection control requirements. Roommates also have to be isolated for 14 days, assuming they have no symptoms, if they have been in a room with a COVID positive person. If there is COVID in the building, the CDC suggests that resident monitoring should be included every shift, and that should include pulse oximetry if possible. They also have considerations that universal use of all PPE for care of all residents in a unit that houses a COVID positive resident, or of course within a dedicated unit, is an important piece. Facility-wide use of all PPE is also recommended whenever a new single case is found, especially when there's sustained transmission in the community. So there is some wiggle room about what facilities can decide to do in terms of ensuring full PPE across their entire staff or groups of staff. But of course, if you're caring for COVID or someone suspected of COVID, you must use the full transmission-based guidelines. And of course, in Michigan, you have to test all of your residents weekly if you have any cases, new cases. The CDC does speak to visitation, and we all know that this is a difficult area and what the restrictions are in Michigan. But the CDC also restricts any non-essential personnel from entering the facility at this point, along with visitors, and actually calls out hairdressers as non-essential. We know this is hard. We get a lot of questions about this, but the guidance is rather clear. So these are the precautions needed for all long-term care facilities. And until MDHHS clarifies and updates its guidance, it seems that these make the most sense to be using. So the following few slides, in terms of content, is applicable to nursing homes only. MDHHS issued a temporary policy yesterday that provides Medicaid funding for COVID specimen collection for certain providers. And it notes that the reason for that is that collection can be burdensome, and so they want to support the providers to do that. What was confusing and somewhat disconcerting to us is that nursing homes and home health agencies were excluded from that policy. And while we would think a huge burden is on nursing homes and other long-term care providers who are testing in large numbers, we do want to affirm with everyone that this does not mean that you're not going to get reimbursed under the current state policy. This policy that is in front of us that was just issued is about Medicaid. And Medicaid is not the payer right now for specimen collection that you might be getting. That's being funded by CARES Act dollars. So everyone should continue to submit your expense information to the state. The only concern we have is that when there are no more grant dollars, it's possible that Medicaid will not cover testing. So that could be a concern for the future. But it's obvious in our conversations with the state that they are fully aware that without financial support, providers would not be able to do this testing. So at any rate, this policy, even though it's temporary, doesn't really affect us, at least right now. A brief update on point of care testing. Michigan now has 16 facilities on the updated priority list for point of care test equipment and supplies. 3 of those are Leading Age Michigan members. The department is meeting with those facilities via conference call later today to discuss possible protocols and reporting requirements. Remember that there is no requirement, at least by CMS or HHS, that nursing homes use the equipment, but we're not sure yet what MDHHS is going to do. Facilities must hold a CLIA certificate waiver, and they will be required to do all the routine reporting that a lab would normally do. So we're interested to see in today's call how MDHHS is going to approach that and how they'll be developing guidance. Tomorrow there is a NHSN data quality webinar, and we strongly encourage nursing home members to participate in this call. The CDC had updated the module requirements for data reporting, and there's now questions and fields for barriers and resources for testing, response times for results, and they ask if the facility is doing any routine facility-wide testing. And these changes were not really announced, but all of a sudden showed up in the instruction link, and that link is included there on the left, along with the module and the webinar link. The department, MDHHS, is currently working on updates to EM Resource to align with this new guidance, but we suggest that you might want to participate in this webinar to find out the details of what they're doing. So that concludes the content for today, and we can now take some questions or comments from our members.
All right, I will just get right into the questions here. I had somebody ask about visitation for our residents, but I believe you already cleared that up. My understanding is all staff members or I am not exactly sure who must complete the infection control information. Can you provide more details about this and the website?
I'm not sure what that's in reference to. Can you repeat that, Blake?
It's about the infection control. Just as my understanding is all staff members or I am not exactly sure who must complete the infection control information. Can you provide more details about this and the website?
Is this for the NHSN reporting?
I will let them maybe type a little something extra, and I'll go on to the next question. So if
okay,
she just said infection control module, I believe.
The infection control module, is that NHSN reporting? Is that the ICAR assessment?
They said they are not sure.
Okay, please, whoever submitted that question, shoot me an email. We can start a discussion, and I can try and help you figure this out.
Yep, and then we will be showing the email shortly, so you would get that soon. With Michigan being at a moderate level, do all, including dietary services and such, have to wear goggles or face masks?
Only persons who are coming in direct contact with the residents are supposed to wear shields or goggles. All people in the facility have to wear a face mask, a face covering of some sort. Persons in direct contact with the residents are required to wear a surgical level face mask. So anyone who's not coming in any contact with residents can wear a cloth mask.
Okay. What leads you to the conclusion that the CARES Act funding for testing trumps the policy yesterday that testing is a routine cost?
Well, because that's a Medicaid policy and it has to do with Medicaid reimbursement. Medicaid is not reimbursing currently any testing or support, or even for specimen collection or for the lab costs at all right now. That's not coming from Medicaid. That's coming from the state itself through the CARES Act dollars. So I already know that. It's not a Medicaid program. However, they're not going to pay nursing homes and home health agencies under Medicaid for those tests, just specimen collection. All the specimen collection monies right now are coming from the CARES Act.
All right. Can we verify the answer to that question today on our call? Dave said, can we verify the answer to that question today on our call?
The call today, it's possible. I'm not sure who's going to be on that call today. Today's call is really about point of care testing, so I'm not sure exactly who will be in the room, but we can certainly try.
All right, thank you. All right, it looks like that takes care of the questions. So if you do need, if you have any other further questions or anything else that pops up, feel free to shoot an email to any of them on the left there. We have the Safe and Calm. Renee, I believe you were the one who had the questions. You can email Deanna directly right there, just deanna@leadingagemi.org. We also have Dalton and Laura Funch's email right there. Just a quick reminder that we will not be hosting a Safe and Calm webinar this Friday, so we will be back next Wednesday at 10 a.m. Eastern Standard Time, just like usual. And then lastly, we would also like to thank both Dalton and Deanna today, and I believe we had around 85 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Other than that, I don't believe I have anything else to take care of. So, Dalton or Deanna, do you have anything else you'd like to say?
I do,
No.
actually.
Okay, go ahead,
Dalton.
Dalton.
Upload. We had a question earlier about the direct care worker payments. I'm going to upload the handouts to this webinar here for those or the forms that you would need to submit those payments. Those payments are due by the 15th of each month to be reimbursed for the funds for last month. So if you have not done that yet, I have attached the forms to this webinar, and you can always email me to get the forms. One is the application to submit to the state via email, and the other is the updated FAQ. So you'll just need to be hesitant about that if you haven't submitted your reimbursement form yet for your July reimbursement costs.
All right, and it looks like both of those documents are already uploaded, so you can just go ahead and click on that little handouts tab and grab the direct care worker wage pass-through and the MDHHS SNF COVID-19 forms. Other than that, I hope everyone has a great rest of their day, and we will talk to you guys next Wednesday. I will also just sit here for about another 15-30 seconds in case anybody else does need to grab that. Thank you and have a great day.
Thank you, everyone.